Well, hello everyone. My name is Frank van Haren, and I'm talking to you from a small island in the middle of the Pacific, which I'll show in a moment, about personalized blood pressure targets in ICU. It's pretty weird talking to your own computer screen, I have to say, but I'll do my best. I have no relevant disclosures for this presentation. And as I said, I'm on that small island there in the middle of the Pacific, which actually looks quite nice when you look at it from the plane. I'm in quarantine at the moment for 2 weeks, and after that I'll be helping out with the intensive care COVID response here. So I'm talking about blood pressure targets, and of course this is essential to what we do every day in intensive care. We have blood pressure targets for every patient that we have in intensive care, because, you know, if you don't have a target, what are you going to aim for? So the question is quite simple, isn't it? Is there an ideal blood pressure target for critically ill patients? But of course, the answer is not as simple as the question, because first of all, critically ill patients are, heterogeneous. It's not the same if you have, septic shock or cardiogenic shock, and even shock is heterogeneous. The shock can be different because it's a different cause of shock. Patients can respond different to shock with their comorbidities, older patients versus younger patients. What's also interesting is that vascular beds have different responses to the treatments we give. I'll show that in a second. And what intervention you choose to target a certain blood pressure also has an effect on what happens. Which vasopressor, will you use fluids maybe to increase the blood pressure? So this study, which is a small but quite important study 20 years ago now, showed that in septic shock, if you increase the blood pressure, the MAP, from 65 with noradrenaline to 75 and then to 85, not much happened really. The lactate level doesn't come down at all. The urine output doesn't really go up. If anything, markers of microcirculation and markers of gastrointestinal perfusion perhaps worsened a little bit with higher blood pressures. We've shown also a long time ago that if you use vasopressin in patients who have high doses of noradrenaline for septic shock, if you add vasopressin to those patients, the gastrointestinal perfusion gets a little bit worse as measured by this old-fashioned tonometry technique. But then again, when you use methylene blue, for example, the opposite happens, and methylene blue improves gastrointestinal perfusion in these patients on noradrenaline. So different vasopressors have different effects on different vascular beds. And it's not true that a higher blood pressure necessarily means that your gastrointestinal perfusion or other vascular beds improves. And different vasopressors, as I just said before, have different effects. What about pharmacogenomics? We also are starting to understand that different patients respond differently to vasopressors. For example, this sub-study, very elegant sub-study from the VAST study, the big vasopressin study from a number of years ago, this study showed that patients who had a single nucleotide polymorphism in a gene close to the vasopressor receptor gene, these patients had significantly more serious adverse events. So maybe in the future it's going to be possible to fine-tune or individualize vasopressors based on pharmacogenomics. What about fluid boluses for blood pressure? People who've heard my talks before know that I'm not a great fan of fluid bolus therapy for a number of reasons. In terms of improving blood pressure and sepsis, as you can see from this study, it is very often the reason to give a fluid bolus, low blood pressure, or perhaps the vasopressor dose that's increasing, and maybe clinicians give a fluid bolus to see if they can stop that trend from happening. But as you can see in this study, that it was only successful in about 30% of patients. In a systematic review of recent studies by Neil Glassford, So he showed quite elegantly that there are not many physiological studies looking at blood pressure response to fluid bolus, but certainly it is quite small. And after an hour, the blood pressure response to a fluid bolus is pretty much gone. So it's small and short-lived. This was the evidence up till 2014 in terms of what blood pressure we should use in intensive care. Only small studies, short periods of intervention, and conflicting results. When all these studies were combined by François Lamontagne group, you could see that increasing blood pressure with norepinephrine will increase the cardiac index, usually will increase the heart rate and perhaps also the risk of arrhythmias, but it doesn't do anything on your lactate level. Then came along this very important study, Pierre Esfar and co-workers, who compared a blood pressure target of 80 to 85 with 65 to 70 in patients with septic shock. In the New England 2014, you've all seen this study, I'm sure, with the hypothesis that a higher blood pressure would reduce mortality. And the secondary hypothesis, which was much more important in my view, that a higher blood pressure would be useful in patients who normally have hypertension. Why do I think that's important? Because the majority of patients that we care for in intensive cares are over the age of 65 and have hypertension. In the States, the majority, 2/3 of patients over 60 have hypertension. And while the majority may be aware of their hypertension and maybe have some treatment, only about 50% of patients have actual control of their hypertension. So back to the study, they achieved a good separation between the two groups in terms of blood pressure targets. And the results showed, as we already know, that there was no difference in outcome at day 28 mortality. However, the secondary hypothesis was true. Patients who have chronic hypertension benefit from a higher blood pressure by having less acute kidney injury and less new renal replacement therapy. So that was quite significant. So there's no need to routinely target a high blood pressure in patients with septic shock, but in patients with chronic hypertension, a high MAP may decrease the risk of kidney injury and the need for renal replacement therapy, with the numbers needed to treat of only 10. Having said that, pushing the blood pressure up to higher levels with noradrenaline will cause more tachycardia and more risk of atrial fibrillation. A similar study was done by the same François Lamontagne in Canada. This was a pilot study, Ovation, where they used slightly different MAP targets, 75 to 80 compared to 60 to 65. And really the primary outcome was to see if they could separate the two groups, which they could do quite nicely, as you can see in this graph. The 28-day mortality, which obviously the study was not powered for, was not different between higher and lower blood pressure. But an interesting thing here, that elderly, so patients over 75, had a better outcome with a lower blood pressure. This was quite counterintuitive, but quite an interesting outcome. And because of that outcome, François then went on to do this really large study in the UK, the 65 trial, that was just published in JAMA a couple of months ago. Quite an impressive study of more than 2,500 patients over 65 randomized into either having a blood pressure target of 65 or 60. There was no difference in the primary outcome in terms of mortality between the two groups. Adjusted and unadjusted, there was no difference. However, when you look at the point estimate, there is a 2.9% absolute reduction in the 90-day mortality in the elderly patients who had permissive hypotension, so a blood pressure of 60. The confidence interval is either a 7% reduction in mortality or 1% increase in mortality, but it's still a point estimate that points towards perhaps benefit and certainly no clear harm. But what if we could base our blood pressure target on a patient's own normal pre-illness blood pressure? And this is work that Dr. Panwar is leading from Newcastle in Australia, and I'm just today the person who can share his results with you. So he first developed a protocol to estimate a patient's pre-illness or pre-morbid blood pressure, and he validated that well. That was published. Then he did a small observational cohort study, and to be fair, but not to complicate things, he looks at mean perfusion pressure, not at blood pressure. So the perfusion pressure is obviously blood pressure minus CVP, because patients with a high CVP may have a lower perfusion pressure for a given blood pressure. What he found that, this is the basal mean perfusion pressure, so what the patients normally have at home, and this is what was achieved in intensive care. So there's no relationship between these two in real life. And even in between 60 and 70 MEP, which is what we usually target in most of our patients, there was a significant degree of deficit, mean perfusion pressure deficit, meaning that these patients had much lower blood pressures for long periods of time, much lower than what they normally would have at home. In that study, he found a signal showing more renal failure in patients who had longer deficit of mean perfusion pressure. And only just recently, we finished this study and was just published in the Blue Journal, a much smaller multi-center study, pretty much looking at the same. So 300 patients over 40 years old, they all had shock requiring vasopressors, and we looked at the difference between the pre-illness mean perfusion pressure and the achieved mean perfusion pressure in intensive care, and the association with outcomes of that difference. So in total, we analyzed more than 12,000 vasopressor hours, and we found that almost all patients had a degree of deficit. So their blood pressure in ICU or perfusion pressure was lower than what they usually had before they were sick. Quite a significant deficit, in fact, and the relative hypotension is very common in patients on vasopressor support. It was one of the findings of this study. More importantly, there was a very highly significant association with kidney injury and the degree of perfusion pressure deficit. As you can see in this graph, you can all read it back in that paper. It's a bit much to sort of compress in a 12-minute talk, but for every 1% increase in time-weighted average mean perfusion pressure deficit, there was a 5% or almost 6% increase in new significant kidney injury, or MAKE-14. And MAKE-14 is a validated score for major adverse kidney event within 14 days. There was also an increase in mortality with an increased mean perfusion pressure deficit. Now, this study is observational. It was not a primary outcome, but it was all quite a clear signal towards harm. The longer patients have a mean perfusion pressure deficit compared to their normal blood pressure, the more harm we do to these patients. Now, this is not new. In a randomized clinical study in post-operative patients, individualized blood pressure based on pre-illness blood pressure was compared to standard care in this large study of 300 patients. And generally, patients who had their blood pressure targeted on their pre-illness blood pressure had slightly higher blood pressures. And importantly, the individualized blood pressure treatment arm had significantly less post-operative organ dysfunction. So to wrap up this talk about individualized blood pressure, some takeaway messages. It makes a lot of sense to individualize blood pressure to what patients have normally. One size doesn't fit all, and there's all sorts of, heterogeneity in our intensive care patients. Different vasopressors have different effects on different vascular beds. That's also important to know. And maybe in the near future, we'll be looking at individualizing targets, but also individualizing vasopressor choices based on pharmacogenomics. For intensive care patients, it's important to look at subgroups. And what we already know is that patients with chronic hypertension probably should have a higher blood pressure target, although we don't know whether it matters whether these patients have well-controlled hypertension or uncontrolled hypertension, and intuitively that matters. Elderly patients perhaps should have a lower blood pressure target, but what certainly has become clear from the study I showed you is that it makes sense to target a blood pressure that is based on a patient's pre-illness or pre-morbid basal blood pressure or perfusion pressure in our study. Relative hypotension is common, even when we just target the 65 to 70 in all our patients. We have a lot of mean perfusion pressure deficit, and it's strongly associated with kidney injury and also with mortality. So an interventional study is currently recruiting, so hopefully we'll have some more results soon. Watch this space. And with that, I thank you very much for your attention. Goodbye.